So the outline for my talk is just that. We wanted to kind of hit those 4 areas, touch on what we know, what we don't know, what are the limitations and potentials for these different areas. Just as a bit of background, this was touched yesterday, but when we talk about circulating tumor DNA, we're not talking about circulating tumor cells, but what we're talking about are fragments of DNA that are free-floating in the plasma that are derived from the tumor. And by that we can see because of the mutations that they carry, for example. You'll see a few other terminologies: circulating free DNA, which is similar and synonymous in first pass. There's also cCF-DNA, another one that is being used. So the field is kind of condensing on some terminology, but you'll hear circulating tumor DNA as well. We won't have time to touch on exosomes, which are the idea that there are these non-cellular membrane-bound vehicles that can carry and protect larger length DNA, can also protect RNA and other species from degradation in the plasma and circulation, and there's been work that's much earlier in development, but also interesting looking at that subtype. Okay, moving on. So let's talk first about circulating tumor DNA in lieu of tissue testing. So why do we need an alternative to tissue testing? It really, in GI malignancies, there is tissue availability. This is a big concern in some GI tumors, less than others. I think we'd all agree that when we're managing patients for multiple different centers especially, but even in the same center, it's timely access to the results, right? I need that information now. I can't wait for it to be shipped from the outside hospital where the patient had their diagnosis. And then the idea that, the quality of the DNA is a problem as well. That's been less of an issue. You may remember back when Sanger sequencing was the realm of the land, there was a lot of, there's plenty of DNA quantity there, but the quality was not sufficient. But that's been less of a concern now. So I think there's a recognition that we can still do better in terms of how many patients that we're testing. So in a older series from MD Anderson, there's a good proportion of patients where there's a request to be made for tissue testing, but the QNS, quantity not sufficient, came back as a result. There was a survey of community sites in the US were non-small cell lung cancer, and a quarter of patients received no tissue genotyping, so a quarter of patients with lung cancer. And then this is a series from Duke. They had a 15% in this small series who'd received prior EGFR therapy, but did not undergo testing for RAS. So of course we can biopsy. We know there's costs associated with that. The costs and charges are of course very complex, but was certainly a substantial impact. And then there's the biopsy risks themselves. And this varies substantially by site, as we've learned. The idea of, and Mike Overman led a report from our institution looking at 745. These were research biopsies, but looked at complication rates. The overall complication rates, major and minor, was 5%. But we know when we're going after things in the lungs, for example, especially deeper in the lungs, that the pneumothorax rate, for example, is elevated. And in this series, actually 17% of patients, so that's a real number. So this is just our experience in colorectal cancer. And remembering that, I'm sure like everyone's experience, that where patients get their chemotherapy differs from where their surgery is. And so there's a series that said 70% nationwide of patients are cared for in a different location. So that's a lot of tissue that has to be shipped back and forth, a lot of opportunities for things to get lost. And of course, this tissue is not available at first pass. Turnaround time, as you can imagine, this is several hundred patients where it takes time to get the blocks in, it takes time to select them. Tissue has to be dissected in many cases and then completed, and then the results have to get back to us, and we have to find time to get back together with the patient to discuss those results. So that's where circulating tumor DNA kind of comes in, and we did a quick pilot several years back just to see how this was going to work and what physicians thought about it, and I'd say this is where we realized kind of the potential for this, and in this setting, this is kind of the low-level evidence of opinion and surveys here, but when we surveyed physicians about these 107 patients, 87% of the cases, the physicians felt that the availability of the liquid biopsy improved the quality of care. Now, you need the right test when you're doing this, and I think this is important when you're doing this for genotyping, that you have to have an assay that has a high sensitivity in order to detect this. The concordance of tissue and the circulating tumor DNA is very high, and there's now many series that have shown this. As long as you have a high sensitivity assay with plasma that's sampled close to the time of tissue collection, you can have discordance that's true because the biology drifts, for example. In general, we're talking about tests where the specificity is extraordinarily high, but the sensitivity isn't quite as high. So when we talk about that, we mean that when you find something, it's absolutely there, to as much as we can ever say that in medicine. But when you don't see something, you're not completely sure, was it there or not, or was it a miss? So the sensitivity varies. Of course, this is less of an issue perhaps in lung cancer, where we're talking about a positive EGFR mutation, right? In colon cancer, what is needed is confidence in the lack of a mutation, right? So you have to be confident that there is no KRAS or NRAS. And so, and that's important because, clearly we know there's at least lack of benefit and detriment in the right setting when we don't treat appropriately. So one kind of practical piece is to just, if you're using these tests for genotyping, in the absence of tissue, to be able to ask yourself, when do I consider it an informative negative, informative wild type, and when is it an uninformative negative or wild type test? And so here is where these multi-gene panels have been useful, the idea that there are other mutations that can occur, right? Classically in colorectal cancer, where we've had the most experience, we're talking about APC, P53, for example, that are present in the majority of patients, at least one of those. So it's this idea of, paying attention to whether or not anything was detected in order to really understand whether or not KRAS is there. So if you see something, the truncal mutation, and this is present at a sufficiently high level, you can feel confident that there is no KRAS or NRAS hiding out. But just remember that just because it says no KRAS and NRAS detected, but by the way, nothing else was detected as well, that may be a situation where you have a kind of an uninformative negative. So keep that in mind. Okay, monitoring response to therapy. So this is the idea that we know there's some limitations to RECIST, that we talked a little bit about the morphologic responses and the limitations of using RECIST or just radiographic data in general. The key, and I think the promise of the circulating tumor DNA, is the idea that this half-life is actually measured in hours. So the estimates vary a little bit, but we're talking about half-life of 2 to 3 hours for the circulating tumor DNA, right? There's lots of enzymes to really pull that DNA out of circulation. So it is a very fast biomarker. And we know, of course, from our experience in protein markers that these change over days to weeks. And so the reality is that when we see changes, it is a much faster process, right? So we can, have a patient go to surgery, right? And the next day, or even later that same day, there should be no more circulating tumor DNA remaining if there was no residual disease. So these changes are also fairly dramatic, right? So it's not a 10, 20, even 50% drop in the level of the circulating tumor DNA. This tends to operate on the log scale, just like tumor right? So the idea that typically we see a 1 log fall in responding patients, and that's been a kind of a rough rule of thumb that we've seen in some of these early studies. So if you see that levels fall greater than 90%, right, these are big changes in these responding patients. This is some of our experience from some of the BRAF clinical trials. Now, this is nice because they all have one particular mutation, right, by definition, so it makes it easy to track the circulating tumor DNA. And so some of the early work in this space has been done in populations like this. And so here's, of course, your clinical trial where you have some responses. You have to wait 2 months to see what the RECIST shows. And in this case, we actually looked at 2 weeks. We could have done it even sooner. And what you can see is there's the lineup of the patients. Couldn't have made it any prettier because of the idea that really aligned very nicely with RECIST. But what you see is a much deeper and faster changes there. So I think that's just kind of an idea to show how we could be using some of this. Now, and this is work that Philip Janku at institution with my junior colleagues helped participate in. Now, that's nice, but when will we use it as a clinician, right? And I think there are kind of a few settings where we're exploring this, and I think there'll be even more creative opportunities and ideas that people will come up with. One of the things that we deal with when we're talking about patients who need a response going to surgery, right? We've talked about this, and we just kind of say, all right, we're gonna pick this cytotoxic chemo and try to get them to respond, but we have to wait kind of 2 months in order to see whether or not the patient's responding to that regimen. And if we're wrong, then we have to turn around and try something else. And at the same time, we know that at least in the setting of liver resection, there's some costs to this, right? There's this liver toxicity that can creep up if we're wrong. So we've been using it occasionally in the setting of that. We said, okay, let's give our first pick, and then we're gonna look in 2 weeks and see if we picked right. And if we didn't pick right, then we can change gears quickly before we start running into this toxicity. And then the second, of course, is this recognition that are there settings where the toxicity rates of the treatments are much greater than our response rates? And I'm sure none of us know any situations like that in oncology, right? But the idea to say, do we really have to wait 2 months with, name your toxic regimen and last line therapy in order to see whether or not the patient's responding, right? Could we give the patient a week of therapy, know whether or not it's worth continuing on to that 2-month restaging scan? So again, just these are the type of questions that this could enable, but I think even more creative ones will certainly come out. So hurdles here are that, and we can learn from CEA, right, that Mrs. Jones and Mr. Smith's CEA levels are not very comparable, right? So they're not good measures of tumor volume between patients. Within patients, it's very good, right? But we just have to remember that there are certainly different phenotypes, and some tumors that we talk about being more secretors than others. But really, this is a composite of a number of variables. It's things starting very early at the genomic level. Are we monitoring something that is amplified, right? We know that some KRAS loci are amplified, so you're going to have much more genomic copies to even be able to be released. There's tumor heterogeneity, how many of the tumors have that particular clone. Then there's the rate of release. So this is both actively and passively released. And so the tumor cells can actively release at different rates, but also just the cell turnover, right? And we remember that cells are turning over at different rates in different tumors, and that can make a factor. Certainly how they're released, apoptotic versus necrotic death, macrophage-mediated can play a role. Different vascularity of tumor, different metastatic sites also play a role. We see it looks like cell for cell, more release of tumor from more release of ctDNA from tumor in the liver than in the lung. There are areas in the bone that actually do fairly well. So that's kind of one area that's hard to biopsy, but that circulating tumor DNA has been fairly successful. And then these are cleared besides the enzymatic. This is also cleared by the kidney, right? So that, patients with renal dysfunction, you're going to see difference, or if the renal function changes over time, that could change. And then finally, recognizing that we're looking for mutant fragments, but we're looking in a sea of normal. I mean, this is literally the needle in a haystack problem, right? And one of the other problems that can happen is that if your haystack all of a sudden doubles in size, it's harder to find that same needle. And so the idea, if there's inflammation, surgery or other just normal DNA that's being released by for any reason, and I've seen it go up in somebody who had a really brisk run. I think they had done a half marathon, and of course, there's a fair bit of muscle damage. I would have much more muscle damage than they did after a run like that. But the idea being that really can cause that wild type to come up. So just keep in mind that there are factors that can influence how much of this we really detect in circulation. Okay, minimal residual disease. I'll just spend a few minutes, I think, and highlight one or 2 points, because we did have some time to discuss this yesterday. Without being too grandiose, this is my grandiose slide, but this idea that, the more we work with this, the more we really get the sense that this is a major step forward. That just like when we went from a chest x-ray to a CT scan, where we got maybe 2 additional logs of resolution to be able to really understand what's going on in the tumor, this is one of those leaps. That we're going from ability to detect things on CT scan now 2 logs deeper into the biology, right? And so that is, I think, really the potential promise. Now, we have to figure out how in the world to best use this information, right? And when is this the most useful? But I think as we look back on this 10 years from now, we're going to reflect on this as one of those transitions, one of those big shifts in how we understand and can detect disease. All right, now off my grandiose stage. So now this is some of the data, and we talked on some of this yesterday. This idea after resection, radiographically, no evidence of disease. Of course, clinically, we know that in a portion of patients, there is microscopic disease that will return. And in several settings, and this is just in the GI settings, but we have now data, now dozens of studies in many different tumor types that have shown very similar results. This idea that, again, specificity is very good when you see this positive ctDNA. In many of these studies, we're talking not about a slight increased risk of recurrence, but near 100% recurrence. In these settings, and I think that's the potential promise. Certainly, there are some that still recur, and the sensitivity may not be as high as we'd like, but we're certainly much further down. So we like this in the stage 2 colon cancer, as you heard. We've been for years working on curves that look like this, right? And kind of as others had mentioned yesterday, the idea that hazard ratio of 1.8 or 2 for risk of recurrence or not. But when we see curves like this with a hazard ratio of 18 and complete separation of this, that really is very clinically meaningful. So and I'll skip this for time, but I think one of the key points is what is it that we are talking about when we talk about how to make use of this, right? Because it's, we all like tests that we can do something with, right? There are a lot of patients that come knocking on the door and say, I finished my adjuvant therapy for stage 3 colon cancer. I want a liquid biopsy to see if there's anything that remains. And I say, no, don't do it, right? That's not the right test to be done because there's nothing that we can do that we know what to do with that result yet. And it's just going to cause anxiety. So how can we use this? Well, when we talk about having disease that remains, the hope is if we're down in this level of ctDNA that with treatment, perhaps not all patients are able to be cleared. Some can, where that can be removed. But we can actually use the outcome of the ctDNA being detectable or undetectable after adjuvant therapy is at least one measure of potential success, right? A necessary but not sufficient step to remove it. So this is the study that the NRG is launching on the basis of this. The idea we was randomized to get the test or not in patients that the patient and clinician, physician agree that there should be no further therapy for stage 2 given the low risk. So this is the setting where to say, can we escalate up to more intense chemotherapy? But I think we also have to recognize that this is a this is a study we have to do because it's not completely clear that we can actually alter the outcomes in even these patients. And so I wanted to take you through one thought experiment here, which is what patients are we curing with adjuvant therapy? And so on the left, this is the log space, right? The number of cells in log space that a patient may have. And here's our line for the CT scan, our estimates of limit of detection, and perhaps where the cut points are for ctDNA at this point based on our best guesses as well. And so clearly we currently are in the mindset to say, if we can see it on the CT scan, sorry, we can't cure you. We can treat you, but we can't eradicate it. If we can't see it, we tell our patients, yep, there's a chance that we can give chemo, we can cure you, right? So this idea that somehow there's this magic line of biology, right, that happens to coincide with whatever limits of detection our CT scan is, really doesn't quite make sense. And I think the reality, of course, is that there's some gray zone here that there is, and gray zone may go all the way down to the bottom, but the idea being that that between this cure is possible and cure isn't possible is this whole lot of gray zone. And right now, with the sensitivity that we have, this middle group is the ones that we're now exploring these adjuvant study designs. And so I think we just have to be careful to say, just because we can detect it doesn't mean that this is the population that we're actually going to be able to benefit with adjuvant therapy. And there's a real possibility that this could be the population that we are not benefiting as much as some of the others. All right, so that's at least a thought experiment to go through. Now, this idea of clearing circulating tumor DNA, I think, is provocative just because of the idea that we can now do these things called a phase 2 adjuvant study, right? I mean, this is a concept we've not really been able to engage on in the field because it's typically you have to have a commitment to a very large study to look at this effect. And as a result, we do very few adjuvant studies because they're very large. And they're only typically with approved therapies, at least in colorectal cancer. That's been what we've done, right? Wait till it's approved in metastatic disease and let's try it in adjuvant. And I think the potential here is with some validation of the ctDNA as a surrogate marker for relapse, now we can actually ask the question in these small proof of concept studies looking at circulating tumor DNA clearance, right? Full stage 3 patients after FOLFOX, and now I will have a stem cell inhibitor that I want to test, right? And if I get a population where there's minimal residual disease by ctDNA, I can ask, can I clear that ctDNA, right? In 40 patients, I could have a signal about whether or not there is actually an opportunity in this setting, right? So my hope is by this technology will really accelerate drug development in the adjuvant space, right? The barriers to entry could be substantially different. Now, this is a surrogate. It's a necessary but not sufficient to clear the ctDNA, and it still doesn't mean that these are patients that are cured just because their ctDNA disappeared, but I think provocative, hopefully, for the field there's opportunities as well. All right, final minute or two on resistance mechanisms. with the idea that this really reflects intratumoral heterogeneity, and there is the potential to really, as we heard yesterday, take the totality of the tumor in the body and integrate it so you get a sense not just of where you biopsied, but this idea of what's the whole the whole milieu of the tumor. And so we'd presented recently kind of a cohort of patients. It was, these are all metastatic colorectal patients, 1,500 patients. And what we saw in circulating free DNA matched very nicely the distribution of mutations on a population base that you'd expect in tumors. But what we're able to do is really to ask what of these mutations are clonal and which of them are subclonal, right? Which of these are present in the majority of the cells in the body and which are subclonal. And so here's kind of the spectrum, and what you can see is there's a whole range that the kind of classic P53, KRAS, BRAF, APC were clonal in the majority of times, whereas there's others down at the other end, such as EGFR mutations that were highly subclonal. And the EGFR mutations were really these ectodomain mutations, right? And so this idea of resistance to EGFR developing this really heterogeneous resistance patterns. And so I'll go through this in the interest of time, but just to say that that there are multiple different heterogeneous resistance mechanisms that one can detect by circulating tumor DNA, which is daunting when we see these, but that's the reality, right? And I think that's the beauty of this technology, is that you can really get a sense of the whole spectrum of what's going on. But these resistant clones are transient, and so there are efforts now underway to really ask the question, can we use this technology and the fact that these are clones that are dynamic, that you can see some where these are plots over time of these different clones where you can see these different mutant alleles come and disappear. And this is one that was the exact same biology of the tumor over time, is just different levels. And then there's others where you see clones that appear and disappear over time, right? And so by using this information, can you then get a better insight into what the biology is? And we're particularly excited by this because these clones are dynamic after EGFR therapy. And there's efforts underway. This is one study that we're doing at MD Anderson as an example, where you can say, are there sensitive clones there to an alternate EGFR strategy? Are there clones that remain when you do one strategy? Or have the resistance clones now regressed, that they were there before, but now they're gone, and maybe that's the patient that we can re-challenge, right? Because those clones, they're at least no longer detectable. And then the other area that you see in resistance patterns is really more understanding what to do next. And so, for example, in the BRAF development strategy, where you treat with a BRAF inhibitor, and then we want to understand what's going on after patients progress. And we all know doing these studies how hard it is to talk to a patient and say, I'm sorry, Mrs. Jones, the therapy is no longer working. But, and I know you're disappointed, and I know the last thing you want to do is to be around here any longer, but would you mind coming back tomorrow so that we can do a liver biopsy of you, right? That's difficult. There are plenty of patients that do it, but we ask an awful lot of them. But if we have blood that we can use to detect that really helps. So in BRAF, this has been very insightful, because every mutation that we've found that has been acquired has all resulted in a MAP kinase pathway reactivation. And that is amazing information that we wouldn't necessarily have had in the absence of some of this. And so now this really tells us and helps rapidly accelerate the next steps, which in this case is kind of a study to ask, what about the addition of MEK on top of the current therapy? So this is, I think, an example of how the field has been accelerated a bit by having this data, and we'll see this be used, and I think there's very few trials coming through now that haven't been incorporating circulating tumor DNA into their study design. So we'll see more and more of this as well. Okay, apologies for going over a few minutes here, but conclude and say ctDNA is an option for tumor testing. Just be aware of the limitations. These changes are rapid and they're dramatic, right? Half-life of a few hours. ctDNA response appears necessary but not sufficient for a RECIST response, as well as minimal residual disease. Perhaps this early information on treatment response can be useful, right? This is where we get to, as clinicians, to put on our hat and say, you know, how critical is it that I know this now versus 2 months from now? And I'm really excited that I think minimal residual disease provides unique opportunities to really change how we do adjuvant therapy and really develop novel approaches in that area. And of course, we're going to learn more, as we always do, about tumor heterogeneity, about tumor biology, but that's probably going to be the one that's going to take longer to actually get into the clinical utility. So I'll end there. Thank you.